what about upfront therapy? What about targeted therapy? I think that the real benefits of local therapy will be in patients with targetable mutations. Why? Because their toxicity profiles are going to be significantly less, touch wood, and because there's a longer potential benefit with the use of targeted therapies in the setting of these patients. So this SINDOS study was a study that was conducted in Asia. And what they decided to do is to take metastatic patients that were starting on a TKI and then give radiation to all sites of disease and basically see whether it would improve survival. This is what we call the upfront treatment. And those patients that received both the radiation and the TKI had a significantly improved progression-free survival outcome. So basically, it gives us increasing signal that radiation is actually going to be actually beneficial. And MD Anderson has a number of these types of studies that are looking at the use of radiation or surgery and consolidation for these patients with targetable mutations, and we look forward to those findings as well. Hopefully, Eric can give us some inside scoop on those things. But here, when I was at UT Southwestern before I moved to Memorial Sloan Kettering, we did a single-arm phase 2 trial that's been submitted for publication to give you a sense of the types of patients that we included on the single-arm phase 2 study. So it's patients with EGFR mutated tumors, and half of the patients had exon 19 mutations, half had exon 21. We had about 40 patients or so on the study. The average age was 65. Majority of the patients were female. But what was interesting is that we included patients up to even more than 5 metastatic sites of disease. So this included patients that had oligometastatic disease, that had what we call polymetastatic disease. And so we included all of these patients. And the idea was that these patients were going to start by receiving osimertinib. And then after about 2 to 3 months on osimertinib, we were going to treat whatever we could treat with radiation. And so these are some of the characteristics of whether radiation was offered or not and why it was offered or not at the time of what we call consolidation. In the kind of fourth box from the top or the second from the bottom, you see the types of sites that were radiated, including the primary lung, bone lesions, lymph nodes, brain, adrenal, liver, and so forth. And so this is just, by the way, a table of the number of studies that are a small proportion of the number of studies that are trying to look at patients with EGFR mutated tumors and to see if we can offer the local therapy in an optimized fashion to improve their survival. Again, part of the rationale is to identify patients that have metastatic disease that we offer the local therapy to before they develop this acquired resistance and may have disease that becomes more aggressive or progressive. And so these are the curves. It's a single-arm study from these two curves, but what you can see is that these patients probably did much better than the historical patients who were on TKIs alone. And I think this is a very illustrative study. What is the goal? What is additional to avoid resistance? The second goal is to allow these patients to remain on osimertinib, which is a wonderful drug, and is in many of these patients still controlling disease at a majority of sites. And so what you can still see is that a number of patients, even at the end of the study, remained on treatment on osimertinib, which is amazing. And we're talking about 4 years out. What we also found was that the arrows point to times where patients were given radiation. And you can see that a lot of the patients were able to be maintained on the drug for a significant amount of time after they were offered radiation, which is suggestive that the radiation and the local therapy did what it was supposed to do.